Good morning, good afternoon, good evening, dear colleagues, dear friends. It is my great pleasure to welcome you all today at our fourth webinar, a six-part webinar series dedicated to the emergency situation in Ukraine, war, psychological skills for surviving and coping with traumatic events. My name is Irina Pinchuk. I am a psychiatrist, director of Institute of Psychiatry of Taras Shevchenko National University in Kiev, country director, International Technology Transfer Center Ukraine, and head of ISSUP Ukraine National Chapter. Our webinar series is a joint initiative of International Technology Transfer Center Ukraine and International Society Substance Use Professional Ukraine National Chapter. At every webinar, I pay attention to the fact that this is just the beginning of a large series of training and implementation assistant events to address various aspects of war trauma. We have already held 3 webinars where we talked about support of adult population in times of war, about specifically focus on first aid for children and how to help people who have become refugees or internationally displaced. We have over 1,000 registration for each webinar. The 3 webinars were attended more 1,000 participants from 73 countries. This is a great honor for us as well as a huge responsibility. All webinar materials are posted on the ISSUP website. The fourth webinar today will focus on all the adults. In Ukraine, there already were 23% of all the adults before the war. And now, when 6 million mostly young women with children have left, even more. According to pre-war United Nations forecast, by the middle of the century, in 20 years, Ukraine will enter 15 countries with more than 40% of people over 60 years old. Today, the principle of 3/4 operates in Ukraine. 1 in 4 is older adult. Every 4th older adult is lonely. Every 4th lonely older adult needs medical and social assistance and psychological support. This topic is really discussed today, which is why we included it in this webinar series. So, it is my honor to introduce Professor Sonia Norman, Professor of Clinical Psychiatry, Director of the Post-Traumatic Stress Disorder Consultation Program through the Executive Branch of the National Center for PTSD. Professor Norman previously directed for the Veteran Affairs San Diego PTSD Clinical, which treats PTSD in recently deployed veterans who served in Iraq and Afghanistan. Professor Norman started our series of webinars. Let me once again thank our colleague for supporting our specialist in our difficult time. I would like to inform the attendees of the webinar that you can send us your question in the chat during the presentation. Please find the chat in the GoToWebinar control panel. You can also find information about the interpretation to Ukrainian in the chat. If time is not enough, questions by email are welcome. Professor Sonia Norman, the floor is yours.
Thank you so much for that wonderful introduction, and thank you for having me back today. Can you confirm that you see my slides in the right mode?
Not
Yeah.
current.
No,
We
okay,
can't.
let me try that again. How about that now?
Yeah, perfect.
Wonderful. I want to thank two colleagues, Lisa Brown and Patricia Watson, who contributed a lot of the content to today's talk. So we're going to talk about some of the unique concerns of older adults in this time of war. And then we're going to talk about some of their vulnerabilities to mental health problems and some of the potential barriers to them getting the help they need. We'll talk about special considerations for treating older adults' mental health, and we'll talk about some applications of stress first aid to help them feel safe and reduce their distress. So that's the goal for today. So let's start with these possible concerns. So one thing that we should keep in mind with older adults is the huge amount of variability person to person. Age in itself doesn't make someone vulnerable to trauma or mental health problems, but a lot of factors that go together with age can impact how they respond before, during, or after traumatic events. So some of these might be, do they have cognitive impairment? For example, some dementia or Alzheimer's. Do they have issues with mobility? Can they get to appointments? Can they leave their house? Or their senses, do they see, do they hear? Those can all make them more vulnerable if they're limited in these abilities. You know, Irina spoke to the loneliness, and certainly one of the risk factors is loneliness or having a smaller or no social network or no social support. And we do know there are elderly people who live by themselves who have difficulty leaving their home, and that those are certainly risks. Limited finances, you know, those who are in poverty may have less access to information, of ways of getting places, even of meeting their basic needs like food and getting their medication, and those are risk factors. And of course, among older adults, there can be a lot of medical problems. Some might be acute problems, some might be chronic problems. They may have pre-existing mental health problems that put them at further risk when they experience new trauma, such as what's happening during the war. So some of the possible concerns or worries for older adults that can exacerbate their symptoms and keep them from getting the help they need is, again, if they have chronic illness or disability. They may worry about, in this time of war, can I get my medication? I need my medication for my blood pressure. What if I can't get it? What if I can't get to a doctor to get the care I need? For some, there are worries about leaving their home. How do I do that? Is it safe outside my home? How do I get where I need to go? They may feel that the people around them, their adult children, other family members, are making decisions and aren't asking them what they think, aren't giving them a chance to contribute, and that could feel really awful, that these life-threatening events are happening around them and they're not part of the decision making. They may feel overwhelmed by new responsibilities that they had to take on because of the war. Maybe they thought they were done with childcare, or they were just helping a little, and now suddenly there's children that they need to take care of. Or maybe there's other responsibilities by those who are fighting or those who managed to leave that are now up to them, and that could feel very overwhelming if they thought they were done with those kinds of responsibilities. They may worry about being left behind as others leave or go to fight, and how will they manage without the help that they're used to, the help that they need. And on the flip side, they might worry about being a burden or holding other people back. You know, these people my family needs to get themselves to safety. They need to be fighting. They shouldn't be worrying about me. And they may feel a lot of guilt about feeling like a burden. And they may want to find ways to be useful, or they may wish they could be useful. They want to help the war effort, but they feel like, you know, because of their physical limitations and other limitations, they don't know how to be. And that could also cause a lot of guilt and distress. Some of these stressors can be exacerbated by not having a lot of money and worrying about, you know, the day-to-day needs being met. For people who do have dementia, we know that that could actually exacerbate symptoms like depression or post-traumatic stress disorder. So they kind of interplay with each other and make anxiety, depression worse when someone also has, memory problems or other types of dementia. And one thing to remember with older adults is many of them have lived through a long life that has involved other trauma, other times of war, other very stressful experiences. For this particular group in Ukraine, some might have lived through World War II, many probably lived through Stalin's regime. And so when they come to you and they're upset and they're worried and they're bringing all this, emotion and difficult behavior to you, it can be helpful to remember that they're not just bringing what's happening right now, they're bringing these other lifetime traumas. That's all mixed up for them and how they're responding. And so that could be why their reaction feels so big sometimes, because they remember how that other thing ended or who they lost that other time. And that's in the room with them too. Older adults who have had past trauma, new trauma can re-trigger that. So building on what I just said, again, you might feel that things are bigger. And what we know with people who have post-traumatic stress disorder or any symptoms of trauma is that certain reminders can trigger them to be very reactive, physically reactive. It might be their heart, their stress, their heart's beating, they're sweating. It can be emotional reminders where nothing's happening right now, and yet they're so upset and they can't stop being so upset. So those are, things in the environment can trigger them, and then those reactions can feel very big, and it's not easy for them to shut that off, especially with cognitive impairment. They may not be able to shut that off as well as they did when they were younger. So when you're seeing someone, if they're triggered, again, you might see this kind of very big reaction. And it's helpful when you work with people to try to understand and help them understand what those might be. Is it certain sounds? Is it the news? Is it seeing certain things? Because you might help them be able to manage those triggers. If it's watching the news, maybe they just need 5 minutes a day to know what's going on. But in fact, maybe they're watching it all day long because they've gotten into this habit and they don't have much else going on, and maybe that's really harming their mental health. So you can figure out what's triggering them and see if you could find ways to help them manage that a little bit more. And a lot of people now are in displacement. They're no longer in their homes. They had to leave their home, their community. This of course is very unsettling for anyone, but for older adults who really count on their routines and maybe haven't faced change in many decades, this could be especially unsettling. And then they might find themselves in some temporary housing situation or facility where there's triggers right and left, and they don't have the privacy, they don't have their routine. So again, when you see them, you might see that they're very amped up, very emotional, presenting with very difficult behaviors that can be driven in part by these triggers. So some of the common reactions we might see among older adults at this time is, of course, they're living through a war, stress, a great deal of stress. There can be a great deal of sadness. For some, that might turn to depression, where it's a really, they really have trouble motivating, doing anything, feeling any pleasure. They may cry a lot. They may have changes in their sleep or their eating patterns. And so depression, we definitely want to identify and treat, and that isn't uncommon. And same with anxiety. Of course, anyone's going to feel some stress, some fear, some worry. But if someone is overwhelmed with anxiety to the point where it's stopping them from making good choices or doing things or keeping them up consistently at night, treatment is good, and we'll talk about treatment. They may be feeling grief over people who have died, but also people who have left that they don't know if they'll ever see again, especially in their older age. They may feel very hopeless that they'll live through this war, about how things will end. And so that hopelessness can really, you can see it in their body, you can see it really permeate their whole being. And what we know about older adults is somatization is very common. So instead of coming to you and saying, I feel sad, I feel fearful, they come to you and say, my stomach hurts, my blood pressure is up, I think I'm gonna have a heart attack. What they tell you about their emotional pain, they don't call it emotional pain, they call it physical symptoms. And so it's really up to you to take that hint and say, okay, I know you have high blood pressure, I know you have these other chronic problems, but I wonder if some of this isn't expressing your stress right now. And that's where it's important to assess and ask questions and understand if what part of what you need to treat isn't depression, anxiety, PTSD, some of these other things. So clearly this is a group where many people could benefit from help, but that isn't always easy for them. So let's talk about some of the things that can get in their way. Again, of course, having disabilities, if they have trouble with mobility, trouble with transportation because of their disabilities, they can't walk to you even if you're close by and they don't have access to a car. So, you know, their physical condition could get in their way of getting help. Maybe they're a caregiver, maybe their health isn't so bad, their mobility isn't so bad, but they're caring for a wife or a husband who needs them around the clock. And so they can't just get away for a couple of hours to go to an appointment to get help. Older adults are less likely to complain and ask for help even when they need it. And we know from some research studies that older adults worry about who they can trust. So they might be less likely to come in because, you know, this is a new program, this is a new clinic. How do I know, you know, these people aren't gonna take advantage of me? How do I know they're any good? And along those lines, they may be concerned if the help is being offered to them is actually going to be helpful. They may be very skeptical, they may feel hopeless, no one can help me through this suffering. And if they're feeling that way, they may be less likely to come in and get the help they need. They also may be confused about how to get help. Who do I call? You know, suddenly there's 20 organizations in my town saying they're here to help me. That's too many, I'm overwhelmed. How do I know who to call, how to actually get help? You know, too many offers can actually shut someone down, so they don't reach out to anyone. Depression gets in the way of people doing things that help them. Depression leads to someone just wanting to do nothing, to lie in bed all day, to not feel that hope that if they get help, that it'll actually make things better. So depression can get in their way of getting help and advocating for themselves effectively. If they have cognitive impairment, such as dementia, Alzheimer's disease, they may feel fear, but have trouble remembering why or what to do or how to get help. Caregivers may find it difficult to find the time or the energy to get help for themselves because all their energy is going to the loved one that they're caring for. And transportation can be difficult, if not impossible, to get to appointments. For people, especially those older adults who live by themselves, you know, rather than with a multi-generational family, it can be hard for people to even know that they're there, to even know that they need help. And so it's important to have a system in place to identify and locate older adults, to know who and where they are, to make sure that we reach them and can give them information about the care available to them. And they may not be getting important information if it's not, you know, on TV or radio, or if they just don't have the same information. They're not on the internet, they're not internet savvy, they may not know how to get help. It's very helpful for older adults to have a trusted authority who tells them, hey, go to this place, they can help you. But many may not have that, and that could be a big barrier to getting help. So homebound older adults, those are the ones who have physical or other limitations where they really can't leave the house by themselves. So extra challenges for them is that whoever normally cares for them may not be available, may have to go do other things or take care of other needs. And they may feel very scared that, you know, I'm not getting the help I need. I'm here by myself. What's going to happen to me? If they're confined to a bed or a wheelchair, or they have challenges with vision or hearing problems, this can add a lot to their stress of just making them feel so vulnerable and afraid and helpless. They may not have the ability to access public or private transportation. Maybe there's a bus that goes right outside their door and gets them where they need to go, but they may not be able to get down there and take that bus. So it's very important that outreach programs are in place that'll locate older adults who may not have the knowledge or the ability or the physical ability to leave their home and stand in line to get help. Another thing that keeps older adults from getting help is stigma. You know, I'm not crazy, I'm having problems because of the war, which is very true, most likely. But that feeling vulnerable, feeling like I'm not going to tell a stranger, you know, how I'm feeling, you know, what do they'll think of me? That what will they think of me can be a very big barrier to someone getting help. And it could be, you know, we know in all countries and all generations, there's unfortunately still stigma around getting help for mental health concerns. But in older generations, that can be particularly problematic, especially in countries where maybe mental health or, you know, psychiatry was once used to kind of control social issues and things like that. They might have very different associations with getting help for mental health than younger generations. Some people don't want to work with government agencies. They might not be able to complete paperwork to get the help they need. And some people prefer to go to a religious leader or family members or their own social network or their own personal doctor rather than go to, you know, somewhere that's popped up to help them during the war. And hopefully if they go to those other places, either they'll get the help they need or those religious leaders, family members, etc., will help them get to where they need to be. So it's okay. They can. We like to say there's no wrong door. As long as someone seeks help, hopefully we can get them to where they need to be. And of course, we know there's a lot of people who are displaced right now. They're not in their homes. They may not even be in Ukraine anymore, which can, again, for an older person, be terrifying, especially if maybe people around them aren't speaking the language they understand. So there could be many potential triggers there, as we discussed earlier. Physical touch might be comforting or it might be terrifying. You just have to kind of feel it out with the person in front of you. They might see things as threats that aren't threats. So again, get to know them, get to know what their triggers are. And keep in mind that all the ways that they used to cope, you know, if it was looking out their window at the pretty tree and birds, all the ways that all the daily structure they had that brought them comfort and routine, all of that is gone. They're in this place, they have no routine, their normal ways of coping aren't available. So it's just very important to keep that in mind, because that could be disruptive to anyone, but particularly for older adults, that could be very, very stressful. They might refuse care even when it's available, partly because they distrust authority or for many of the other reasons we discussed. If they're asked too many questions too fast, especially if their brain isn't processing that quickly, they might just shut down and stop talking or just stop giving, you know, helpful answers. So it's important to kind of pace yourself, keep things very simple, very slow. We'll talk more about that in the next part of the talk. And for older adults, it can really be new trauma can really push them into thinking about the meaning of life and the meaning of their life. Was it worthwhile? What did they contribute? So they might be in this very kind of deep, thoughtful kind of time, and they might bring that into their conversations with you of, did my life mean anything? Did I do anything worthwhile? So again, listening and helping them kind of think about some of those things might be an important part of the work. So let's talk about treatment considerations for mental health in older adults. They may come to you and present differently than younger adults. So younger people may admit more to symptoms because they view mental health differently, they view treatment differently, they have fewer stigmas. So it might be harder to get that information out of older adults. Younger people may have a better vocabulary for psychological problems to talk about their feelings. whereas older adults may have talked about feelings very differently than we do today, and it may be harder to get the information about what they're experiencing. Again, it might be a lot more easier for them to label their problems in terms of somatic complaints. This hurts, that hurts, rather than saying, I'm sad, I'm scared. And they may not understand what psychotherapy is. So if that's something you can offer them, you can come and talk to me and we'll work on your trauma and we'll help you get better. This may be completely unfamiliar to them, and maybe they'll be open to it, and maybe they'll just be like, this is garbage, I don't know what you're talking about. So it might take some work to get them to the point of just being open to getting that kind of help. So when you meet with an older adult for the first time or ongoing, some of the things that are particularly important, and these aren't that different from meeting with people of any age, but might have particular impact with an older adults or be particularly critical, is that compassion. They're gonna be feeling you out. Are you trustworthy? Do you care? Are you just part of the bureaucracy? Are you just, wanting information from them for your own purposes? Or do you really actually care how they're doing, what they need, helping them? So coming across as interested, compassionate is so important. And it's hard if you're in a situation where you have to see 50 people today or 20 people today for that matter, and you have 20 minutes and you need to move on. So you need to get the information quickly and go. But coming across that way can really backfire with an older adult. They need to see that you're with them, that they have your attention, that you're listening and that you care. So coming across that way is just so important. And so taking those few minutes to listen, and when I do have 20, 30 minutes with someone, I do tell them that up front, so that then if I have to say, hey, do you mind if we move on? And because I want to ask you these other questions, because it's so important I understand this about you to help you. They don't feel necessarily rushed for no reason. I've already explained to them up front kind of what the parameters of our meeting are. And that can be a helpful way if then they're, I ask them one question and they start giving me a 30-minute explanation, and I have to say, hey, this is so important, but I would just want to make sure we get to this other information that's so important too. They understand then when I'm coming from. When you meet with an older adult, again, you may not have the information exactly about their cognitive functioning, how much they're going to understand, how much they're going to remember. You may not know how well their hearing is. I know a lot of the older adults in my life don't always wear their hearing aids, but they're very good at acting for a little while like they understand what I'm saying. And then it slowly dawns on me that, even though they're nodding and saying some correct things, they really don't. So you're not going to know right away. So just in case, you want to keep your messages simple. Don't give them too much information. Don't overwhelm them. Give them a few key pointers. Just to jump down a little, if you give them any recommendations, like go here for this resource, or try this strategy to relax, or do this thing, keep it simple, write it down big in case they have vision problems and maybe their glasses aren't even going to be helpful enough. If you're printing things, print it in a big font. So do what you can to ensure that they'll understand and retain the information, that they won't forget it, that they won't be able to not read it. If you do need to refer them to others, if possible, do what we call a warm handoff, which is that you don't just write down an address and hand it to them, because that might be too much for them to get to another place, to get to another person. If you can, if it's someone nearby, walk them down the hall, take them up to that other floor, make the introduction, and then leave them there. That's what we call a warm handoff. If that's not possible, maybe call the person together so they make that connection, and maybe have them make an appointment while you're sitting there. As much as you can assist in the structure around that, they'll be more likely to make it to that other service that they need. One thing I find helpful, because again, I've noticed a lot of times when I'm working with someone, I think they're understanding what I say, and then it dawns on me much too late that for one reason or another, they're not, whether it's dementia, whether it's hearing problems. So one thing that might be helpful is early on, ask them to repeat what you said. That both tells you if they're hearing you and also if they're understanding. And if they're not, then you can take what you're doing down a notch, you can adapt it. But if otherwise, you can have the reassurance of, okay, they're understanding me. And the bottom bullet, the reason I have all the stars around it, connect with feelings. This is incredibly helpful. You know, when you're meeting with an older adult and they're triggered and they have the trauma and they have all these anxieties around being left behind and getting the help they need, when they come to you, that might come out in behaviors that are really hard to be in the room with. They might be yelling, they might be angry, they might be already telling you that you can't do anything for them and you're useless. They might, you know, be crying uncontrollably. They might be, you know, not barely speaking. Whatever presentation it is, maybe they're fine, or maybe they're presenting in a way that's just challenging for you, especially if you're like, okay, I have these 30 minutes with them and then I need to move on, and all I'm getting is they're yelling at me. Do they even want my help, or are they just so, you know, are they just this angry person who just yells? Some advice that I got very early on in my career that I think about almost every day when I work with clients is not to look beyond that behavior and try to understand the feeling that's driving it. So in their case, maybe it's fear, maybe it's grief, maybe it's the depression. I'm going to say a lot of times it might be fear and anxiety. And that way, even though they're yelling at me and telling me I'm useless and telling me how awful everyone is, I can be aware of that, but I can work with their fear, and I can say things and assess things and do things that that attend to that fear. And often, if you attend to that anger, they stay there. But if you can actually get to the feeling that's underneath that difficult behavior, and they see that you're connecting to their fear, that you understand it, that you're doing things about it, they will settle. So dealing with that anger, they may not settle. Dealing with the feeling that's driving that anger, they may settle. So highly encourage you to think about it that way. I find doing that is very transformative in terms of me being able to help people who are otherwise presenting in a way where it might be very difficult to help them. Their behavior makes it difficult to help them, but connecting with the feelings instead of the behavior is a strategy that can be very powerful. Again, it might be hard for them to talk to you about what's really going on because they come from a time when people didn't talk about personal things that might have been very dangerous to do, and they've learned that over the course of many decades. They might come from a time of more traditional gender roles where, you know, men don't talk about their feelings, only women do that. And women don't talk about, you know, if there's violence at home or something, because that's just not done. Or maybe in the past, they've tried to tell someone about some trauma they've had and it didn't go well. The person didn't respond well, or they ended up in trouble for it. So those experiences will drive how they speak with you. In terms of actually offering treatment, I realize that, you know, we're in the middle of this war, and this may not be the time that you're able to say, okay, let's do 12 weeks of psychotherapy every week at the same time. That may just not be where things are right now. So we're going to talk about things you actually can do more right now. But just to lay the groundwork for these ideas, I do want to say a few things about treatment for when it is possible, or if it is possible where you are. Assessment is very important to understand the problem, understand their diagnoses, understand what they want from treatment. So you can assess by talking to them. You can give them questionnaires that ask about symptoms of depression, about post-traumatic stress disorder, but we want to zero in on what diagnoses they have and what their goals are, because that will really drive the treatment plan. And the treatment plan should be collaborative. because they don't have to show back up. You can say, this is what you need, we're starting next week, done. And maybe they'll come because they're older and they listen to authority, and they'll do that. Or maybe they'll say, okay, thank you. And then they'll go home and say, this guy doesn't get me, or this woman doesn't get me, I'm not going back. So it's very important that you develop that plan together. Are you open to medication? What are your concerns about medication? We have these psychotherapies for depression that really help. It would take coming 6 times and talking to me about this and that. Are you willing to do that? Which one sounds more interesting to you? Help them be a decision maker. It's very empowering for them. It could help them feel better. And also it'll ensure a treatment plan that they're more likely to actually come back for and let that treatment help them. For specific diagnoses like depression, PTSD, we do have treatments that work, that have been researched quite a bit. We have therapies and medications. Some of the therapies that work the best are trauma processing therapies, which means we help them process the memory, the emotion around the traumatic event. And these really help people recover and feel better going forward. And we do have research with older adults, and they do work for older adults. If someone has very severe dementia, they probably won't work, but short of that, they do work. So I'm just going to give you some names right now, and I know you don't necessarily have access to people who do these, but we'll come back to that and maybe even make some training available down the road. But prolonged exposure, cognitive processing therapy, EMDR, eye movement desensitization and reprocessing, and written exposure therapy are some that we know work well. So again, just really want to highlight that we don't have to say, oh, this person is old and hard of hearing and set in their ways, these therapies won't work. No, no, no. The research shows that therapies do work. No major modifications are needed. Maybe slowing things down if there's some cognitive decline. Sometimes people say, well, I can't ask someone with high blood pressure or with heart problems to talk about their trauma. Their symptoms will escalate, they'll have a heart attack. That doesn't happen. Certainly you can consult with a physician, but they can in fact talk about these memories without, and in the spirit of doing that to get better, and they are able to do that. Caregivers, their loved ones can be brought into treatment as well, if that helps them come and do things and understand what's happening. But if they have very severe dementia, that of course can get in their way. So sometimes it's those symptoms that have someone come to their doctor, and instead, all they may know about is asking for medication, or again, they may talk about, these physical problems instead of the emotional symptoms. So really, physicians seeing these older adult patients right now, they should really be looking for that. Is what this person talking about possibly related to trauma and the symptoms related to trauma? And if you can assess their mental health, ask some questions to understand if that's contributing, that could be their doorway to getting the mental health help they need. These are some medications for PTSD that we know work well. They're antidepressants. They also work well for depression. So, SSRIs, we call them, SNRIs. I know there may be issues with the availability of these. So again, I'm just putting this out there. There are other options, and we will down the road have a talk on that as well. The one thing I want to highlight right now is it's best to avoid prescribing benzodiazepines. They seem like they could be helpful for older adults because they take that anxiety down so quickly. But for older adults, they don't actually work that well. They increase their risk of falling, and other safety concerns. People adapt to them very quickly and need higher and higher doses. They can be addictive. So even though they may seem like a good option to kind of quickly bring down that very present, very high anxiety, they come with a lot of risk. So I would really caution against using those. And if you are someone who prescribes for older adults, this can be difficult because they are sensitive to side effects. Side effects can last longer than in younger bodies. And often they'll come to you already on 5 different medications for their different physical conditions. And then, you have to think about those interactions when you add anything there. So appreciate those complexities for sure. So to finish up about treatment, older adults may present with somatic symptoms, help them understand that mind-body relationship so they can get the help they need. Treatments can include medication, therapy, or combinations, and it's really important to consider what the patient wants, their life expectancy, their overall health, to make choices, and to offer treatments that we know work, the evidence-based treatments when possible. And it's not always possible, but when possible. Dementia can make the symptoms look worse, and cognitive problems can get in the way of psychotherapy. And so it's just very important that this kind of information is shared with your whole team so they know what to look for, they know what to do, ongoing training and education to the extent available. And this talk will sit on the website as the other talks have, so please feel free to share it with your team. So I want to, I know that what I talked about for treatment was in some ways very aspirational at a time when a war is going on. So I do want to give you some tools so that if you see someone and you want to leave them with some hope, with something, I want to give you some suggestions. And so we did a previous talk on stress first aid, which is ways to help people in the time of trauma, like in the middle of a war. I won't go over this extensively because we had a whole hour talk on it and I don't want to be too repetitive, but remember that we talked about strategies for having people feel a little safer if they can, a little calmer, more connected to others around them, more hopeful, more confident, feeling like they have a little bit more ability to make change and do things. So that's the heart of the model. And in the hour talk, we went deeply into each one of these and how to put them into action. Today, I'll talk about a couple of strategies consistent with this model that may be helpful to older adults that you see. And generally people's concerns will fall into their physical health, emotional, social, psychological, their symptoms, and financial. So, we often think if someone's in deep financial problems or if they're really unsafe where they are and need to get to a safer place, those come first. But if they're relatively safe, or they're as safe as they're going to be for a while, if their medical needs are met, if they, have access to food and those basic needs, a roof over their head, then we can start thinking about what else can we do to help their psychological health, their emotional health. How do we help them feel a little better now, and also have them doing things that we know in the future predict that they are less likely to have depression, PTSD, ongoing emotional problems. So one area we could intervene on quickly is doing some things that can maybe help them feel a little bit more competent, have a little bit more confidence and hope. And one way to do that is to work with them to find even small positive activities they can do, things that they find meaningful, things that they find enjoyable. Again, if they've just been scared and hiding during the war, or if they're depressed, they may be doing nothing. They may be doing nothing at all. They may be watching, TV that just makes them feel worse all day. So even little things can make a difference. It can help them feel a little bit more in control, a little bit more like life is normal. It can give them moments of a little bit more hope and less sadness or fear. Just moments. That's all we're going for here. If it's more than that, great, but we're not shooting very big. We just want to do something to help them feel even a little better. And we want to remind them that if they do these things, it'll help their health and well-being. So when you talk to someone about this, you can say, look, people often stop doing things that are rewarding or meaningful or enjoyable in very stressful times because they're busy coping with other problems, like there's a war. They just don't feel like it anymore. They don't want to be reminded of things. They don't feel safe. They might feel too sad or lacking in energy. Everything just takes too much energy. But what we know is that doing things actually helps someone feel better. So you might say, I feel really bad. Help me feel better. Well, let's work on my feelings. It's very hard to work directly on feelings and change them. But we know from a lot of research that if you change your behavior, it can change your feelings. And so that's what we're going to try. Also, when you plan something that you think will be meaningful or enjoyable, you look forward to it. You anticipate pleasure. So even if you're not doing it yet, you will look forward to it. So you'll explain that kind of rationale, and you'll identify even one thing they can do. And you'll schedule it with them in a calendar, because otherwise they might forget, or they might say, I'm too busy. So it's really helpful to talk with them about when they might actually do this thing you've identified, and put it in for 2 o'clock on Thursday. So it's there, and hopefully it's a calendar they check. So we need to choose activities that are safe in the context of war. Prepare them for the fact that they may not be as enjoyable as before, but maybe they'll be at least a little bit enjoyable. Find something that still matters to them, that's still important. Something that'll give them just a little break from their everyday stress, and let them know that you get that this is hard, that even just doing something small like this can be hard. It's important that you convey that you understand that. So things you can pick might be something that helps them relax. It might be something that helps them feel safe or closer to others. Maybe, we talked earlier about one of the concerns older adults might have is doing something to help the war effort. Maybe it's something like that. If there's a way they can make something or do something or share with the information with others that can help them feel like, I'm doing something to support Ukraine, that might feel very powerful to them, very meaningful. So they should choose something they think they would enjoy or would be meaningful, something they can actually do. Don't set them up for failure, right? If taking a bus cross town and going to a park they used to love is not safe right now, or that bus isn't running, we don't want to make that the activity. It's something that they should be able to do, that's practical, easy to set up. It's easy to say they'll do it for you and then feel too tired, not motivated, bad, and not do it. So again, putting it in that calendar and talking with them about, okay, if you feel this way, how will you get yourself to do it anyway, can be helpful. So, and then if they come back to you and they actually did it, or even did part of it, or even thought about it, congratulate them, find the successes, reward even the smallest steps. If they didn't follow through, see what got in their way and help them with that, and make ongoing plans. Connecting with others is also incredibly important. And what may have happened during the war is they may have become more isolated. They may have lost touch with people who left or who are fighting. They may be worried about people. They may just be more isolated, more lonely than they were even before. So making even a small connection, whether it's by doing something in their community, reconnecting with a friend, a family member, can really help them feel connected. And we know from a lot of research that feeling connected to others is incredibly protective psychologically, and protective from future psychological problems. So it can help them feel understood, like they fit in, like they're needed, they matter, they're important, they're not invisible. It can help them feel more confident that they can handle problems. It could give them someone to talk to and get advice from. So you help them identify, who they might want to connect with, and maybe it's one person, maybe again it's going to an organization and helping, or just somewhere where they can talk to people. You ask them questions to help them, to help you understand what they can really do, and help them identify what might be helpful. Are there ways that this might be difficult, and how do we help them overcome those barriers? And you help them make a plan. What's one thing they can do differently? One concrete step. Can they call someone? Can they write someone? Can they go somewhere? What is their goal for the week? And just like with the pleasant activities, you put it in a calendar, you write it down for them, you have them leave with the plan. And then if they come back to you, you say, how did it go? What did you do? What worked? Revise the plan based on their experience. I know that, in this time of war and the deep distress people are feeling and older adults are feeling, it might feel like scheduling a pleasant activity or connecting with someone, these feel so small. But these are things that are doable right now. Potentially, you can find ways that are reasonably possible and safe. and they can really change that person's day-to-day experience. They can add meaning and connection. So just final thoughts, that support and empathy from you, it's the first step to everything. Nothing else happens if they feel like you're a bureaucrat who doesn't care. You have to come across with that empathy and caring. You have to consider who's in front of you. Just because they're over a certain age doesn't mean they're the same or have the same concerns or limitations as the other person you saw who's the same age. So you have to kind of assess what's going on with this person. It's not the age, it's those other factors like their health and their mental health and these other things that will be important. Consider what their barriers are to getting help and help them with resources for those. If possible, offer treatment and at least use these stress first aid strategies to help them have a little bit relief in their day-to-day life and prevent future mental health problems. These are some resources that are in the slides for more information on mental health in older adults, and especially in times of disaster, trauma. So hopefully these will be helpful to you. And I will stop there.
Okay. Thank you very much, Professor Sonia Norman, for your presentation, for very interesting and useful material for us today. Now we have time for some questions. First of all, I would like to thank our participant for submitting the question. Question number 1. How to talk with elderly people or how to talk with elderly relatives about evacuation if they don't want to leave home?
Yeah, that's really, really challenging because someone can be very set on not leaving and they might say, I'd rather stay. We have an American expression, the devil you know might feel better than the devil you don't know. So even though it might be extremely dangerous to stay, they might say, well, that's what I want to do. So I understand the challenge there, and it'll be different for everyone. I think it's important to listen to them and understand why they don't want to leave, because that might be different from different people. Someone might say, I don't want to leave where my wife is buried. And someone else might say, I just don't want to go to a new place. I don't know what it'll be like. It's too frightening. So to the best you can understand their specific concern, you can help address that and help them think about it in a bigger way. Like, what can you take from your wife that you could look at every day so you could still remember her, versus, here's what we know and we'll be together. Isn't being together, that's the familiar. It's not the house, the apartment, it's that we're together. So once you understand why they don't want to leave, it gives you more room to help them address those concerns. And again, be empathetic. It is hard. It is so scary for an older person with physical limitations, right? So show that compassion, show that empathy, understand their specific concerns, and think with them about how to make those a little more palatable.
Okay, thank you very much. Maybe the next question's something the same. What is more traumatic for elderly, to stay in a dangerous place, for example, active military operation, or to evacuate it to an unknown situation with other traumatic moments?
That's a great question, and that'll vary person to person. Again, I would want to understand their specific concerns. But for some, yeah, staying where they know, where they have the routine and the familiar might feel better than going to the unknown. And it's true that the unknown may have its own stressors and traumas ahead. So I don't think there's one right answer for that. Again, I think understanding their concerns and helping them work through those is really important. But they do have so many reasons why they might want to stay, but from the history they have with the place, the loved ones that are there, their physical concerns. Who will care for me? Who will feed me? Who will make sure I have my medication? Here I know where to get my medication. I know which bus to take to get food. They don't know any of that. So I think understanding their concerns and helping them know that those will be taken care of, and probably much, much better than if they stay. And, you know, in my own experience, I found that older adults who are very, very wary of change, once they make the change, they actually adjust much quicker than they think they will. So some reassurance around that can be helpful as well.
Thank you very much. Thank you very much, Sonia. The next question, is there any connection between mortality and trauma in elderly?
There is, and unfortunately this will have to be the last question I take because of my next talk, but there is research suggesting that PTSD, you know, those who develop PTSD after trauma, and even those that have trauma history, that is a very big burden on us physically, and it can contribute to a whole host of chronic health problems that may lead to earlier death, and maybe even PTSD directly. But I think that the pathway that's usually accepted is that PTSD contributes to the physical health problems, which are then maybe the causes of death. And we know that if there's also dementia on board, those really interact and can also contribute to mortality. So, you know, these are from very big studies, epidemiological studies with tens of thousands of people, and maybe the rate of, you know, the change in mortality, in fact, is very small statistically. So I don't want to make too big a deal out of this. It's not like every older person you see with PTSD will experience this, far from that. But statistically, there is a relationship in these very large epidemiological studies.
Okay, thank you very much. The next questions.
Oh, I'm so sorry. I would love to take more questions over email. I'm happy to receive them after, but unfortunately I have to go to my next talk.
Okay, okay. Maybe it will last questions, okay?
Okay.
So please, I heard that there is another method of therapy for PTSD by using psychedelic drugs. Supervised by the therapist. How do you think about that?
So that is really still under investigation. There's been a couple of studies, but not to the level that we would say that's an effective treatment. That's an evidence-based treatment. So we're in an exciting time with PTSD in that we're studying some potentially very interesting and effective new directions, but we can't say yet that that's an effective treatment. We really can't. The research just isn't there yet. So for my own patients, I say, I know you're seeing all the stories about it. I know it sounds really exciting, but can we start with what we know works? Because you're giving me this chance to treat you, and I want to give you what we know works.
Thank you. Thank you very much, Professor Sonia Norman. I would like to thank everyone for participating in our webinar. Special thank you to you for your contribution in our webinar today. Also, I would like to say thank our technical support. Olivia, thank you very much for your work with us today, and looking forward to meeting you soon at the next time. We will have the 5-hour webinar, Priority Assistance to the Military, and then the last webinar, Overview of PTSD and PTSD Treatment. We are waiting for you. Take care and stay healthy. Thank you very much.